listen to Professor Collins' presentation.
Okay. All right then. So we have a brief intervention by Mr. Satish Videsi on his experience with a testicular cancer, which is close to the prostate, and as a cancer survivor himself. So, Mr. Satish Videsi, please, you may present at this point.
Thank you very much, Dr. Gabriel, and appreciate the opportunity provided with you as hosts, with colleagues, as well as the Caribbean Cancer Portal. And I really want to congratulate the effort towards targeting, addressing, and responding to the issues and the significant issues of men and cancer in particular. As it relates to testicular cancer, I would imagine coming from a conversation, a significant one on prostate cancer, was a connection with prostate cancer and testicular cancer? Well, there's none. In fact, there's a vast difference between them. And that's just a pun, because the vast difference is actually the tube that delivers the sperm out to the testes. So there's no connection, but of course there's some type of anatomical association, at least from a conformational perspective. I just want to share with you guys a brief presentation about my experience with testicular cancer. And literally, testicular cancer, it takes balls. It takes balls at a figurative perspective, but also from a literal perspective as well, because for the testicle that's affected, the indicated treatment or part of the treatment is to remove the affected testicle. Now, my presentation is going to speak very briefly about testicular cancer background, and then I'll focus on my experience itself. From the WHO's perspective, they classify testicular cancer in different categories, but the main ones include, well, seminoma and non-seminoma. Seminoma is very common. Non-seminoma was my type. It's not as common, but we also have germ cell tumors and intratubular germ cell neoplasms. Seminoma versus non-seminoma. Seminoma is quite localized at the testicle level. It's very radiosensitive. That's a good thing. That means it's responsive to radiotherapy. Tumor markers are not as useful in terms of predicting, detecting, diagnosing seminoma. It's very indolent. That means it's long in terms of its pathogenesis and its development. And that allows for its manifestation physically at the testicular level. Non-seminoma germ cell tumor is more likely to be metastasized at presentation. It's quite mobile. It's not radiosensitive. That means it's not really prone to be treated with radiotherapy. Tumor markers are useful as indicators of tumors, and it actually involves a lot of hematogenic spread, which is part of the metastasis and makes it quite a complication. This image to the right was my ill-defined hypoechoic mass on my left testicle. I felt nothing, actually. No soreness, no discomfort, no palpable lesion on my left testicle. From a pathogenesis perspective, the thought process is that as part of gonadal development at the fetal level, there's maturation of cell types, in particular as germ cells differentiates themselves from germ to different types of specialized cells. Then at some stage, there's a neoplastic arrest that occurs where there is a halt in development. And then for whatever time period, there is an onset of a malignant transformation. And that malignant transformation commonly occurs at the seminoma level or a non-seminoma level. I'm not certain what causes that transformation, but this is fairly young, comparatively speaking, for men. It can occur at the late teens to even the early 30s, which is the general range in which this transformation can occur. In my case, it was in the very early 30s. From an epidemiology perspective, the median age of diagnosis is 24 years. It's a young, well, comparatively young disease for men. Geographically, the highest incidence is in Scandinavia. I don't think that's an issue, except that maybe they have better public awareness, better diagnostic capabilities to actually develop records that demonstrates a high incidence. From a race perspective, if they're diagnosing it more, then it tends to suggest that there's a potential risk, and that may be the case, but I'm also thinking that the health system may be part of that bias. From an etiology perspective, cryptorchidism, if you have undescended testicles, that can be a risk factor. If you have testicular cancer in one testicle, then the other testicle, the contralateral testicle, may be also at risk. In terms of rates, between 2010 and 2020, less than 1% of all cancers were actually testicular cancer. So it's not routine. But fortunately, we have about 80% survival for testicular cancer. And this is according to the Global Cancer Observatory. From a treatment perspective, back in the 1970s, about 90% of testicular cancer patients died. But then, interestingly, there was an experiment using platinum electrodes on E. coli broth. And what they found at the platinum electrodes level, that the E. coli bacterial cells, they stopped dividing and then died. So there was something with platinum that was interrupting cell division, cell development. Platinum-based compounds would then develop and apply to cancers, including cisplatin. Cisplatin is now common practice for different types of cancers, and especially successful for testicular cancer. In terms of treatment and management for seminoma, it's usually radiotherapy because it's sensitive to that. usually by surveillance, and that's at the early stage, low risk. At the intermediate stage, usually it's radiotherapy combined with chemotherapy. And at the advanced stage, usually it's chemotherapy for the seminoma, and of course accompanied by an orchidectomy, removal of the affected testicle. For non-seminoma germ cell tumor, you really want to get into surgery fairly quickly, but also chemotherapy because of metastasis and hematogenous spread. So even at the low stage, at the low risk stage, you want to try every option. You want to try surgeries, you want to try chemotherapy, and also followed by surveillance at the low stage, at the intermediate stage, and certainly at the high risk advanced stage as well. From my experience, back in 2015, as I am a private pilot, so annually I have to perform aviation medical exams. And interestingly, in April 2015, based on my history of right pelvic reconstruction, I routinely have to do x-rays of my right pelvis. And I'm making this as my reference point because in April 30th, 2015, based on my x-ray images at least, which is, of course, it's very basic, but there was no observable, demonstrable radiographic lesions in my pelvic area, my inguinal area. That was April 30th, 2015. On June 20th, 2015, I observed a left axillar swelling, which was unresponsive to antibiotics and anti-inflammatory treatment. Upon further examination using ultrasound in my left axilla, it demonstrated lymphadenopathy. A chest, abdomen, pelvis CT scan was then ordered together with tumor markers, well, blood profile generally speaking. The CT scan images showed essentially showed peritoneal lymphadenopathy, especially around the periaortic lymph nodes, and tumor markers were done, as well as a biopsy of that left axillar lymphadenopathy. Tumor markers demonstrated my LDH was elevated, so generalized inflammation was occurring. Alpha fetoprotein, AFP, was elevated, and my beta HCG, human chorionic gonadotropin hormone, which is for pregnancy, that was elevated as well. So it showed clinically that I was pregnant and my fetus was in distress. From the biopsy of my left axilla, it showed that CD30 antibodies and cuboidal cell Schiller-Duval bodies, which is synonymous with embryonal germ cell type. So my diagnosis was non-seminoma embryonal germ cell carcinoma. As part of preparation for management with bank sperm, at that time, no children, and today sterile, stem cell collection was done, especially in the post-management treatment options provided. Organ function was conducted as baseline measurements and assessments, and central line incision was done for chemotherapy infusions. I received 4 cycles of bleomycin etoposide cisplatin. Essentially, 1 cycle is 1 month. Usually, first week it's 5 days of cisplatin etoposide. Weeks 2 and week 3, you get bleomycin added onto the protocol, and then week 4 is a break. It's a nice rest week. And the daily regime starts from 7 a.m. and goes all the way into overnight, usually, for different types of fluid infusions, chemotherapy regimes, as well as post-treatment fluid and clinical review and observations. A couple of complications, though. Neutropenia ensued. I had to receive granulocytic colony stimulating factors on a regular basis to promote my response, my immune response, as well as manage risk of bleeding, especially with thrombocytopenia, which also occurred in particular for bone marrow suppression. Tumor markers over the cycles, my tumor markers increased, understandably, because with chemotherapy, my body was undergoing further inflammation. So my LDH continued to increase throughout chemotherapy, which is consistent. My AFP began to reduce. In fact, by the second cycle, both my AFP and my beta HCG was within normal range. So I was at that point in time that I'm good to go. Let's start the treatment and let's move along. But that was not the case, because even on PET-CT monitoring, the lymphadenopathy associated with my periaortic lymph nodes, they persisted. There was less uptake of contrast medium, but there was still lymphadenopathy, which is of concern, especially in the context that my cell type was germ cell, and there was a concern about different types of developmental anomalies. Because with germ cells are omnipotent, and you can develop teratomas even. Post-chemotherapy, now let me just backtrack. Routinely, from a protocol perspective for testicular cancer, you usually perform the orchidectomy first. You remove the source, and then that can be followed by chemotherapy. But because I already demonstrated some systemic involvement with my left axillar lymphadenopathy, the decision was made to proceed with chemotherapy because there was metastasis, and then we'll follow up with the surgical procedures post-chemotherapy. So post-chemotherapy, we conducted an orchidectomy, left orchidectomy, as well as a left axillar lymph node dissection, removing the lymph nodes from the left axillar region, and biopsies all confirmed that it was essentially fibrotic tissue and necrotic tissue. So the chemotherapy did its job between testicles and the lymph nodes of the left axilla. After that, the periotic lymph nodes remained enlarged. So the concern was those lymph nodes may be a potential source of potential teratomas or potential development later on. So the decision was made to conduct a retroperitoneal lymph node dissection, which essentially is to remove the lymph nodes from the mediastinum all the way down to the pelvis into the inguinal area. Essentially, that was the experience, but from a day-to-day perspective, the management included nutrition, exercise, cleanliness, care and attention, and of course, managing mental health. Outcome, I've remained clear ever since from a markers perspective as well as an imaging perspective. Surveillance change from 3 months to 6 months to annually, whether it's tumor markers or imaging. Prognosis, as I stand right now, I pass a 5-year survival, and I am projected to have a fairly normal life expectancy, provided the West Indies continue to win those games in the World Cup. Otherwise, I think my hypertension may be my cause for demise. From my perspective, Single Jingles is a group that I'm associated with that work with cancer awareness, especially testicular cancer awareness, and supporting persons affected with testicular cancer. Final thoughts, this is me. My job was easy. It was just to sit down and look cute. But it was those that are around me, my family, my friends, my colleagues, my healthcare practitioners. They carried me through this process. So I really want to encourage those from a cancer perspective generally, but for testicular cancer specifically. Cancer is a word, and it's not a sentence, but it does require, not as an individual, but a team-based approach to manage. I appreciate the opportunity to share the experience and look forward to contributing to the awareness of cancer and men. Thank you.
Thank you, Mr. Bidesi. You're such a brave individual to share such a personal experience with all of us here. But I think it's very instructive. You know, strangely, coincidentally, I have a gentleman in St. Lucia with a germ cell tumor who is actually from St. Vincent. And he presented it with metastatic germ cell tumor, a seminoma germ cell tumor. And we had to give him chemotherapy. So it has been quite an experience. His was very full blown with visible masses in the neck, lymphatics of the neck and so on. You know, today we were able to give him his leave after finishing chemotherapy. So I know the ordeal that you go through when you confront an illness of this sort, which usually is invisible to the naked eye and very few symptoms initially. But, you know, when it does develop and spread, you have major illness. And, you know, the battle is a serious battle. Thank you so much for sharing with us and encouraging other persons with that kind of illness to confront it head on, because once you are positive, you will have positive outcomes. Thank you. Unfortunately, we won't have time. I'm sure there are many people with many questions for Satish, and you know, I'm sure there are many questions. I'm sure you would be willing to contact him even after we end our program tonight. But it's time for us to proceed to the next very intriguing area of cancer care and cancer management by talking about colorectal carcinoma. And it's my privilege and my honor to introduce to you all Professor Shamir Kawich, who is a professor of liver and pancreas surgery at the University of the West Indies, St. Augustine campus. Professor Kawich obtained his MBBS, Bachelor in Medicine and Surgery, from the University of West Indies, Mona, in 1998, and his DM in General Surgery in 2005. His resume, his CV, is about close to 100 pages. So, but I would say that he is a fellow of the Caribbean College of Surgeons. Professor Kawich has been at the forefront of research and investigation in the region, among all the universities in the region, and he's highly respected throughout the world. He's a fellow of the American College of Surgeons as well, a fellow of the American Hepatopancreatobiliary Association, a full professorship in surgery at the University of the West Indies in 2017. And as we go on, you know, he lectures in general surgery currently at the University of the West Indies. He lectured in general surgery in 2008 and 2010. He currently has full professorship in surgery at the University of the West Indies, Trinidad, UWI, West Indies. He undertakes undergraduate teaching, postgraduate teaching in the DM in general surgery. And his experience with gastrointestinal cancers, colorectal cancers is extensive and certainly well published from the region and among international experts in the field. So it is my pleasure once again to introduce to you Professor Shamir Kawich to present his experience with colorectal cancer in the region. Professor Kawich.
Thank you, Owen. I must say thanks to Dr. Gabriel and to the organizing committee for this opportunity to speak to you today about colon cancer. And thanks to the audience for giving me your time. So we're going to speak about colon cancer in the Caribbean. I hope you can see my screen.
Yes, we can see your screen.
Fantastic. Every one of these faces we will all recognize, because every single one of these individuals have been victims of crime that was based on their race. This is racism. That's what racism looks like. We're all familiar with the bias against gender, feminism. And the mere fact that every one of us in this audience will know the names of these three gentlemen is testament to the fact that discrimination by wealth or by classism does exist. But something that also discriminates that we're not very much aware of is this. This is the face of colon cancer. You can see to the right of your screen what the nice, supple, normal inside lining of the colon looks like. And on the left side, you will see this large, ugly, ulcerating, hard mass. That is colon cancer. And you will understand why it is discriminatory in a second. Here's another face we all know. This is Chadwick Boseman, better known as the Black Panther, the undefeatable, forever strong leader of Wakanda. Well, even this gentleman, at the young age of 39 years, 39, developed advanced colorectal cancer. And even though Forbes magazine estimated his net worth at $12 million US, and even with all the fame and all the influence that came with being the Black Panther, and even with the fact that he lived in the country that spent the most on its citizens' healthcare, spending over 10,000 US per capita on the citizens' healthcare in the US. Despite all of this, he could not beat colon cancer. Why? Because colon cancer discriminates. The reality is that in Black persons and Hispanic persons, colorectal cancer occurs at a much earlier age. And when they're diagnosed, they're usually diagnosed at a much later stage. They're associated with several gene mutations. That means that these tumors go from 0 to 100 in a much more aggressive form. They spread quicker, they respond less well to treatment, and even it does happen, there is a disparity in access to healthcare for Hispanics and Blacks compared to Caucasians. It still happens today. And we are particularly disadvantaged as Caribbean persons, because we just said that the United States spends 10,000 US per capita on their citizens' healthcare. And there is data that in the Caribbean, we spend a measly $160 for healthcare. So you can see we're already at a disadvantage here because of the composition of the race of the majority of Caribbean countries, because of this healthcare expenditure. So I'm sure you will agree with me that this is something that is important for us to talk about. And I think it's a good way to talk about it by looking at this data from the World Health Organization. Now, this is a graph. And on the left-hand side, you will see many different countries across the globe. And at the bottom, the x-axis, it shows you the number of new cases of colon cancer in a population per year. That's what we call the incidence of colon cancer. And we can see many blue bars. Look at the top. You can see blue bars indicating a high incidence in men and in women. But if you look at the countries where the incidence is the highest, you'll realize something. These are rich countries. We're talking about Europe, New Zealand, North America. So they have a very high incidence. And if you look at the bottom of the graph, you will see that poor countries, like countries in the African plain, South Central Asia, Central America, they have a much smaller blue bar, which means that they diagnose significantly less cases of colon cancer per 100,000 population per year. Now, the Caribbean falls smack in the middle of that graph. And initially you might say, wow, well, that's good for us because we don't have the high rates that the developed countries are seeing. But actually, this graph is much more sinister story. If you agree with me that there is one metric that is important with colon cancer, and that is keeping patients with cancer alive, then you will understand why this graph looks pretty bad, because the graph also in red bars reports deaths from colon cancer. That's what we call mortality. And let's look at that graph again. Rich countries, they have a very high incidence, lots of cases being diagnosed, but only about a quarter of their patients that are diagnosed die. In other words, they're doing a good job. But look at the poor countries. Oh no, almost as many patients that are diagnosed will die from colon cancer. Almost as many. And that means these countries are doing a bad job at treating colorectal cancer. And if we are honest with ourselves in the Caribbean, we're not doing that great ourselves. At more than 50% of the cases that we diagnose are dying. So we're not doing as good a job as the rich countries are. And we have to ask ourselves, why? Why is that? And there are many people to blame here. Healthcare workers are to blame. The policymakers and the ministries of health and the government share some blame. There are lots of things. Patients can bear blame as well. And look what I mean here. This is a medical article that was published in a good journal. And these researchers published this looking at the incidence of colon cancer in a Caribbean country. And what they did in this graph down here is they classified colon cancer by stage, early stage, intermediate stage, and advanced, where it has already spread in gray, dark gray, and black respectively. And while this is good data, this is actually telling us something very disturbing. Look at the red bars. The red bars are the largest for men and for women. And if we are saying that colorectal cancer is such a dangerous disease that we need to treat with respect and reverence, yet these people who publish research are saying, well, we don't even know what stage the patients presented at in the majority of the cases. That shows you a complete lack of disregard. And so this is one of the things that healthcare workers need to improve on. We need to treat this disease with reverence and with respect. Secondly, Rohan spoke about screening a few minutes ago. Screening is basically where you take a test and you apply it to the general population in the hope that you can pick up this disease early. And for colorectal cancer, there are two ways to screen. You can check the stools for the presence of blood, or you can do a colonoscopy to actually look within the colon. And every single person across the globe agrees that screening is good in colorectal cancer. It detects disease at early stage and allows us to treat it so that we can achieve a cure. And because of that, every country across the globe has their own screening guidelines, which are pretty much similar. Well, following this, in the Caribbean, the Caribbean Association of Oncology and Hematology convened a group of experts in 2018 to come up with screening guidelines. And one of the first things we recognize is that we cannot treat all cases of colon cancer like the developed countries, which are predominantly Caucasian in their population, do the way they do. They start screening at the age of 50. But with our higher incidence, more aggressive disease, we all agreed we should be starting screening at the age of 40. It's a different disease. And that is because when we pick up this disease early, as you will see in the red line, you will have a much better survival than when you pick up disease late, as is evidence here in the green line. Huge difference. That being said, I am disappointed to report to you that there is not a single country in the Caribbean that has a screening program. Not one. The only country in the Caribbean that has screening is Cuba, but there is no English-speaking country in the Caribbean. And that is something that we should all be ashamed of. And this is why policymakers need to step up their game. This is something that is basic and it's critical. This is something we need. And that's why we, in an attempt to reach out, authors of this paper said, listen, guys, we really need to get screening into Caribbean countries. And it's a shame that we don't have, because when we attempted to start screening in this center in Jamaica, in a small population, we found that 1 in every 5 persons who we screened colonoscopy already had polyps. And these are the polyps that will turn into cancer if left alone. And worse, 17% on top of that already had colon cancer and had absolutely no symptoms. They were being screened. Here's another paper that we published from Barbados. This was led by Sally Griffith in Barbados. And this was shocking. What they showed was that while these persons do get cancer in their 60s and 70s, like developed countries do, check this out. 30-year-olds and 40-year-olds account for 10% of our cancers. 10% in 30 and 40-year-olds. That means if that we started screening at 50, we would completely miss these guys. And this is an example was Chadwick Boseman that we spoke about before, cancer at the age of 39. And more shocking, the data that we looked at showed that when we diagnose cancer, you know that we talk about stages of cancer, stage 0 and 1 being the early stages that we can cure, stage 3 and 4 being the stages that are less likely to be cured. And look at this, guys. More than 70% of colon cancers in Caribbean people are diagnosed at stage 3 and stage 4, when cure is much less likely. These statistics are alarming, very alarming and very disappointing. So we have to understand that we are a population at risk. And if we're honest with ourselves, we're not doing a good job at early detection and we're not doing a good job at screening. So is there good news? Let's see. If we're not picking them up early, what happens to them when we actually diagnose them with cancer? When we diagnose them with cancer, then we have to treat them. The most important treatment is to remove the cancer, and that's surgery. Now, this is a schematic of the colon. We have the right food comes in through the small bowel and goes into the colon. It goes all the way around until it reaches the anus and the rectum. And I've drawn in here in red a spot of colon cancer. We know that colon cancer spreads through lymph nodes. So when we operate on patients, what we want to do is to follow this black line, to have a good margin in front of the cancer, behind the cancer, and right around the cancer, removing enough of the lymph nodes. And thankfully, we have some good news because of the University of the West Indies, which serves as 17 English-speaking Caribbean countries. We have now trained enough surgeons. Rohan and I are both products of this university, and UE graduates who are surgeons in every Caribbean island who can perform these kinds of operations. These we used to do with open surgery, making a big incision to take out the part of the colon that was affected. We don't do that anymore nowadays, and that's because by making an incision, a cut so big that we have to put in these 2 big hands, we're leaving patients with a large incision. So now what we do is we use these instruments, which are about the size of a number 2 pencil. And we put those instruments through a port, as you can see here, to go into the patient's tummy. You can see it's much smaller than my big hand. So by putting the instruments through this port, we are creating less injury, and so the patients can recover much more quickly. And then, of course, instead of looking down, you're looking up at a visual feedback monitor to perform these operations. And then the cancer is removed. I'm pointing to it there. So we no longer do this. We no longer give patients bags, colostomy bags. We no longer make these big incisions. We no longer put in drains. Those are things of the past. This is what we do now. We operate on patients using the laparoscopic approach, and they recover much more quickly. This is my friend, Neil. And when we were in university together, Neil, at the age of 28, was diagnosed with colon cancer. And as my friend, I operated on him. And I snapped this photo 3 hours after we completed his surgery to remove his colon. And look at his smile. You would never know that he's had surgery. Some of you don't believe me. But the giveaway is this. You can see the urinary catheter, and there's a little bit of blood in his catheter where I roughed up the bladder a little bit, trying to take out this cancer. So you can see that patients who go through laparoscopic surgery actually don't have a bad recovery most of the times. And there is now a wealth of data from Caribbean countries to show that we are doing laparoscopic colectomies in the region with very good outcomes that are comparable to any first world center. And this is just an example of what we do. Here you can see those little instruments. I told you they're the size of a pencil. Here, obviously, it's magnified because when we're doing laparoscopic surgery, we operate under magnification. What we've done here is we've identified one of the vessels that feed the colon. And in an attempt to stop bleeding, what we're doing is putting on little clips that are made of titanium to occlude the vessel or to ligate them before we cut them so that there is no bleeding. And everything we're going to do at open surgery, we're going to do at laparoscopy. So here we've taken out the cancer. You can see the cancer in the background here. And what we're doing is using stitches to close back, to join the two ends of the colon back, so avoiding a colostomy bag. More modern techniques that we can use are to join the colon back using staples. Using staples, as you'll see here, this is the part of the bowel that we've the proximal part, that's the distal part. You see we have a device in the colon that we're going to use to staple both ends of the colon back together. This is in a patient with rectal cancer. All right, and you'll see shortly a little portion of it coming out, that thing that looks like an ice pick. We will couple them, and then once they're coupled, staples will do the rest so that we can avoid a colostomy bag in this patient. So I have put a check here because I think since all Caribbean islands can offer this kind of treatment, we're doing a good job with surgical treatment. Here's the bad news though. Because of that data published from one of the Caribbean islands that shows that 70% of our patients are diagnosed at the late stages, or as you would have heard somebody say before, metastatic disease, that means disease that has spread, then we have a different kettle of fish to deal with. This is a patient whose abdomen we've opened. You can see the colon down here, and all of these little spots, these white, yellow spots are areas where cancer has spread. And this is bad news when it occurs because we've already said that compared to early stages of disease, the survival rates drop seriously when you have advanced disease. When I operate on somebody with stage 1 disease on this red line, they have an 80% chance to survive to 5 years. When you have a patient with stage 4 disease that has already spread, the chance to live past 5 years is 1%. And with chemotherapy, that increases threefold to 3%. There is some data that with the most advanced chemotherapy regimes in the world, the best drugs you can get in the entire world, there is such a significant rise from 1% to 10%. But while statisticians will get very excited about that, as human beings, that's poor. 10% survival rate at 5 years is not good. Luckily, patients have an option because half of those people with spread have spread to the liver. So this is a liver that we've taken out of Anthony. And here you can see the normal beefy red liver tissue and this big, ugly, hard white mass, that is colon cancer that has spread to Anthony's liver. And we've removed it in an attempt to give him a better option. So if we can actually, this is the liver in situ, these are my retractors, and this is normal liver, and you can see the cancer here, big, ugly, buccellated. If we can make a cut along here and remove that diseased portion of the liver and leave healthy liver behind, then we've removed this patient's cancer. Yes, it is a much more risky operation, a big operation, but it is the only thing that can achieve cure. I told you that with the best chemotherapy drugs anywhere on the planet, you will get a 10% survival rate, best case scenario. Well, if you undergo this operation, the survival rates with metastatic colon cancer increases from 10%, best case scenario, to about 80%. So that's the only thing that will get you down here, up here to a better survival, better chance of survival. Not obia, not prayers, but with complete treatment. And that's the only time we start to talk not about 5-year survival, but 10-year survival. And this is available in the Caribbean. Here we're removing somebody's liver. You can see we're elevating the liver here. So the liver is created in my hands. We have rotated the liver completely to identify big blood vessel behind the liver. And now we've removed that liver with cancer, leaving only a small portion of healthy liver behind. And we have published data to show that in the Caribbean, the results of these big operations are just as good as any study in first world centers. Not only straightforward, simple resections, but even complex liver resections are available in the Caribbean. Here's an example, and this is a CT scan, but the important thing here is that this asterisk represents a spot of colon cancer that has spread to the liver. It's in a bad place. You can see this, and this white line. These are actually vessels, and this is the big blood vessel labeled V that goes to the heart. This is in a bad place because we can't remove that cancer without damaging vessels. And if these vessels are damaged, it's not compatible with life. So this patient was refused surgery in Miami. You can see when the patient stands, you can see actually the cancer invading into the vessel. She was refused surgery overseas and came home, and we took her to the operating room. These are the 3 vessels that you saw on the CT scan. And what we did was we did a special maneuver that we've described here, a hanging maneuver to cut the liver right down to the blood vessel. Here's the blood vessel again. And we know that the cancer is where the asterisk is, and we actually cut out a chunk of this blood vessel and repaired it. You can see the suture lines here so that this patient was cancer-free. And Selma went on to live for another 9 years after this operation. Here's another patient from Barbados. Same thing, much bigger, much badder cancer, invading into the blood vessel at multiple points on both views of the CT scan. That's what the cancer looks like when we took it out at operation. Here's the hanging maneuver again, and the big blood vessels that we showed you that we need to preserve. So even complex things, guys, are available right here at home in the Caribbean. I told you that we no longer do open surgery for colon cancer with the big cuts. We do them laparoscopically. And similarly, these liver resections are done laparoscopically with similar outcomes. And here's an example. This is a patient with colon cancer that has spread to the liver, but this one we're doing laparoscopically. And you can see the liver looks nice and beefy red. But right at this point, you see a big ulcerated white lesion. I just glanced over it, right? Because we're now assessing to go ahead with the rest of the surgery. That's a gallbladder that we're lifting up to try and use as a handle for the liver. And you can see me here starting to cut the liver. This is the cancer. We're starting to remove the cancer from this patient's liver. And we use a combination of staples and lots of special tools to get it completely removed. Again, with results that are comparable to any center in first world settings. I've already showed you this paper, but I'm showing you again because I want to demonstrate that there is still a problem. Even though these things are available in the Caribbean, look at this. This is the paper I showed you before. It's a paper that, one of the papers that we published showing that the results are good in the Caribbean. But if you read the paper, you'll realize that we are doing, this is the biggest site for liver resections in the Caribbean, and we do 14 liver resections every year. 14. This is a map of the United Kingdom, and here in the south is Southampton General Hospital, where I did some training, some of my training. We served a population of 1.4 million people in the southern part of the United Kingdom, and we were one of 4 hospitals that offered liver resections. There was one in Plymouth, one in Bristol, and one in Reading. So we were the 4th. And still, a few years after I left, my colleagues published this paper from Southampton. And look at this. They reported that in 3 years, they did 413. And when you do the math, that is 11 resections per month. We are doing 14 per year. And if we say we have more aggressive disease with a higher rate of colon cancer that has spread, and we have the same exact population, where are these patients going? That's a problem, guys. That's a problem, because if they're not having this surgery, they are dying. They're dying because they're not accessing the complete care package. And it's a shame because I've already showed you that this is probably the best way to improve survival of patients with colon cancer that has spread. So when we talk about metastatic disease, I have an asterisk here because yeah, it's available, but patients are not accessing it in enough of this treatment. There are also some adjuncts. Yeah, we have a long way to go. There are also some adjuncts. For patients, we've already said that liver resection is the best way to treat cancer that has spread. It has the best survival rates. And the next best is chemotherapy. But there's sometimes when patients can't have surgery, they might be too weak, too old, too sick. The cancer might be in a bad spot. And if we go to chemotherapy as the next available step, that is a significant downgrade in terms of their survival. Luckily, there is another option. There is something that we call ablation. And this is this relies on chemistry, really. It has survival results that are not as good as surgery, but better than chemotherapy alone. And it is available in the Caribbean. It relies on chemistry. We know that water is made up of 2 hydrogen ions and 1 negative oxygen ion. And in normality, they kind of line up so that positive is near negative, so that there is equilibrium. But if we put a magnetic field around these cells, these water cells, then all of the positives will line up on one end and all of the negatives will line up on the other end. And so let's do that. Let's apply a magnetic field to the patient's cancer. All of the water molecules will turn in one direction, right? Negative oxygen will turn to the positive pole, positive hydrogen will go to the negative pole. Now, let's rotate the magnetic field from one side to the next. And what we'll realize is that the water molecule has to turn 180 degrees. Now let's keep rotating the magnetic field. Left, right, and you'll see that these water molecules have to now go over each other. And every time they turn and rub against the next water molecule, they create friction. Now let's multiply that by 1,000 times. The rapidity with which these water molecules will turn will create so much heat that it can generate heat that goes up to 450 degrees Celsius. 450 degrees Celsius, that's more than the boiling point of water. And so we use that sometimes. What we do is we insert a needle, we activate a magnetic field and rotate that magnetic field, and this literally cooks all of the cancer cells in the patient's body while they're still in the liver. This is called a microwave ablation, and it is available in the English-speaking Caribbean. The bad news is, again, it's been woefully underutilized. That's what it looks like at the end. And therefore, even though adjuncts exist, we're not using them. So again, another asterisk, guys, we're really not doing good with grades here. Lastly, I just want to make a point. And that point is that those of you with some knowledge of biology or human anatomy know that textbooks will say, this is what the liver looks like. You can see a small left lobe and a big right lobe. The surface of it is nice and smooth and glistening. Smooth. But that's not what we see in the Caribbean. When we see patients in the Caribbean, this is what we see. Abnormally shaped livers with big grooves coming down them that anatomy textbooks say don't exist. And you might think it's just a one-off, but we've actually shown in several publications that no, this is something that we see with regularity in Caribbean people. 15% of unselected people in the Caribbean have livers that look like this instead of what textbooks say they look like. As I said before, textbooks don't even acknowledge the presence of these things. Not only do we have them on the top, but we have them on the undersurface of the liver as well. And the liver is supposed to have only one blood vessel coming up to it that breaks into 2 to feed both sides. Check this out, 1, 2, 3. Again, something that we see with alarming regularity in Caribbean people. We also see that almost 1 in 3 people have abnormal veins. Look at this. This is the normal vein in the liver that's treating the right side. This patient has something that doesn't even have a name. Actually does have a name. It's called an inferior right hepatic vein, but textbooks in Caucasian say that doesn't exist. Yet we see this all the time. 1 in 3 Caribbean people have this. And this person was lucky. They had this red arrow is pointing to a spot of cancer. And because they had this accessory vein that's not supposed to be here, I was able to cut along this white line and save a large portion of this patient's liver. So that's a good thing for them. Here's another example. You can see one blood vessel coming up to the liver, and it breaks into one on the left and one on the right. That's normal. Check out this knot of blood vessels. This was not described, was not seen ever in the whole world until we described this right here in the English-speaking Caribbean. And it looks complex, but suffice it to say that this person had plenty abnormalities. But again, the point I'm making is that Caribbean people are different, very different. We're different in composition, we're different in anatomy, we're different in what kind of diseases we get and how these diseases progress. And therefore, the practice of getting on a plane and going to a first world center where these things are done, where you think you may have better access to healthcare, that doesn't necessarily exist, because I guarantee you that these people in first world settings, they don't see these things at all. And so this is, we're just saying that there is good care in the Caribbean. And even though we have a lot of areas where we need to pick up our socks, we can still make a big difference if everybody works together. So the take-home message I want you guys to leave with if you have symptoms, make sure that you seek care early, and you have to know all of the options that exist, all of the options, right? Because only when we detect these cancers early can we make a big difference in your survival. Thank you very much. I'd be happy to take any questions if you have any.
Thank you so much, Professor Cowich. As I said, you have not, let us down at all. We didn't think that it could get any better, but it did. We are now captivated with the work that you do in your center, and especially because you are able to take care of patients from around the region. You have a nice collection of different experiences and a good, quality, repertoire to speak to. I've started at the beginning. We spoke about the need for this talk for men, especially. You showed it in your presentation about men and women in terms of the colorectal cancers, and we know that October is Breast Cancer Month, and women get to the forefront of cancer, and we know prostate cancer is for men. But whilst in the region, these have become put on the front burner. I have always said that it's important to keep note of the incidence of colorectal and gastrointestinal cancers in our region for both sexes. How important it is, the incidence and the mortality that you were able to show initially. So, among doctors, we speak of a medical language, and sometimes we speak the layman's language. Is there a need for us to speak the political language so that our policymakers and our politicians open their eyes to the importance of proper interventions in our settings so that your kind of work can be more meaningful for the general population?
I mean, yes, Owen, thank you for that question. I totally agree. A lot of the countries in the English-speaking Caribbean have a government-run healthcare system. And while I acknowledge the fact that many of the Caribbean countries are I'm gonna use the word poor, because they don't have enough financial resources to allocate to healthcare. I mean, most countries allocate only a small proportion of their budget to their citizens' healthcare. But I think it's important, as you said, that we reach out to these policymakers, to the ministries of health, to the governments, to say, guys, we can do simple things like just implementing a screening program will make a big difference in what we can do. And, the government speaks the language of numbers, money. So if we can reach out to them and say, hey, if you catch these people with colon cancer at stage 1 and we treat them with simple interventions, then you don't need to pay all of this money to have very high-end interventions like a liver resection and so on. You know, so I think there is definitely a need for us to approach the policymakers. We need them involved, and that's the importance of groups like this. Yeah, but yes, I agree with you. It is something that we need to do better on.
We have heard of the need for screening. In recent times, they have had home diagnostic tests for occult blood and so on. How important and how effective are those in our setting?
They are very effective. In fact, in some developed countries, this is the method of screening that they use. They will mail out. So they will mail out these kits. You take them at home, you check for the blood in the stool, and you mail them back. And that is a screening. You don't even have to step foot into a formal healthcare institution. But they are effective. They are simple. They are cheap. And in the end, guys, any form of screening is better than zero screening. So I would fully endorse the use of these home kits. You know, and I think we should go even a step further. And this needs to be something that is run by the respective ministries of health and the respective governments, because it is shameful that not a single English-speaking Caribbean country has a screening program. And we need help. We have been screaming about this for decades. So again, the importance of a group like this, because not only should this information come from the healthcare providers, but the patients and the layperson need to raise their voices too, so that we all get heard as a group. That's the only way things will change.
Absolutely. I certainly agree. It is now 8 p.m. I mean, how time flies when we deeply involved in a very productive conversation. We have some questions in our question and answer chat group. The first one is about what about costs? I mean, I would say initially just for the screening test, the home kits screening. What about costs for those? And I assume that about costs for the interventions that you described in your presentation.
Well, I can only speak about cost in the setting where I am, but in this setting, the cost for the home kits is just under $100 United States per kit. And I mean, for something that will help you to diagnose and prevent the prevention of cancer, that is a well-spent $100. In my setting, I see they're also asking about costs of the interventions and whether they're available in government healthcare systems. Again, I am only able to honestly speak about our setting where I practice in Trinidad and Tobago. And the answer is yes. Laparoscopic colon resections, liver resections, all of these things are available in the healthcare system through the government at no cost. But that is not for the entire English-speaking Caribbean. But yes, it does exist. Obviously, the more high-end interventions are going to be more expensive. So simple removal of the colon is going to be a lot less expensive than if we're talking about a major liver resection and reconstructing vessels and all of this. So again, going right back to screening, the earlier we detect it, the simpler it is, the less cost you pay. The worse off you leave it, which is where we are across the Caribbean in 2024, the more work you have to do and the higher the costs are going to be, and the less the rewards.
Absolutely. We have a question from Sadiqa George. Please proceed.
Good night, all. Very good presentation from all the speakers. I've been listening and learned a lot tonight. My question for Doctor is just to have him confirm that he does not do any colostomy anymore.
Yes.
And then I have a follow-up.
So in the older days, surgeons used to believe that colostomies would prevent the area that you join from leaking. But we've recognized that to remove the bag and reverse the colostomy, we have to subject patients to a whole nother operation, inclusive of its cost and risk. So we now practice what's called a fast-track surgery. And the principle of fast track surgery is to avoid anything that will make this patient worse, and colostomies are one of them. So yes, we don't use colostomies anymore, except when it is absolutely, absolutely unavoidable. So the colostomy rates now have gone from maybe 70% of complex operations down to about 5%.
I was beginning to get a bit worried because we're still doing colostomies in surgery on at Milton Cato. But my next question is, are you able to anastomose the bowels in all cases given the size of the cancers that you would have identified?
The only time we're not able to anastomose the bowel is when the cancer is so close to the anus that there's simply no space left to anastomose it to. And that in that case, then we have no option. You have to get a colostomy because, in other words, the cancer is so close to the end, removing it removes the end of the bowel. And that is pretty much the only time that we are not able to anastomose it.
Thank you very much, Doctor.
You're welcome.
Thank you for your question. We have another from Online Counseling Jamaica.
Sure.
Hello there, Prof. Susan Lowe here. I'm just asking 3 quick questions. What the meaning of the whitish groove liver is? Can a vascular variant in a liver be misdiagnosed as a hemangioma on ultrasound? And the last thing is, instead of these packages which they send out in the developed world, can't we as GPs just send to the lab for the blood in the stool, or that's not good enough?
So the first question was, what is the meaning of the whitish lines in the liver? Those are what we call hepatic grooves. And they are basically due to underlying vascular malformations in the liver and abnormal structures that are present in the diaphragm in Caribbean people. You heard Rohan Dishong talk about the incidence of prostate cancer that was due to genes. This is something that's due to genes. And we've worked quite long on this, but the theory is that this is all a remnant of slavery. And that's because during slavery, they would have captured slaves from the western coast of Africa. And obviously, they're looking for the biggest, strongest, most muscular slaves. And after they put them in the bottom of the ships, the weak ones die, the strong ones live, and those are the ones that are deposited in the Caribbean. So we have self-select or artificially selected out people with high testosterone levels, big muscle mass. And one of the things that causes vessels to grow is testosterone. And it all ties back in. This is why we have a high incidence of colon cancer, of prostate cancer. This is why we have all these anatomic abnormalities and funny looking livers. They're all tied back into the same thing. They are related to high testosterone levels and vascular malformations. The second question.
That vascular, yes.
I'm sorry.
Can those variants be misdiagnosed as a hemangioma on ultrasound?
Yes, and this is the point I was trying to make. Because these things are not present in the standard textbooks, very few people know about them. We know about them because we see them all the time. But if you have, let's say, a radiologist who looks at something and is not used to seeing this abnormality, then they're going to misdiagnose it. And so the simple answer to your question is yes, there are many ways that all of these malformations have been misdiagnosed in the past. And the last question was the presence of occult blood. Yes, you can check for that. That is a way for checking for blood in the stools by sending stools to the lab for occult blood testing. In fact, in developed countries, it is actually the general practitioners who do this. The specialists don't get involved at that level. I hope I answered all of your questions.
Thank you so much. I don't know how many more questions you will entertain tonight. We've had you, a very exhausting presentation. I just wanted to ask, with respect to the occult blood testing, we now do the FIT test,
correct,
which is absolutely more costly in comparison with our previous wake testing.
Yes, so the immunohistochemical the FIT test is also available. Yes, it is a little bit more pricey because it uses a little bit of a different mechanism looking for breakdown products of blood. It is quite effective, a little bit more costly, but I go back to the statement I made before. Any form of screening is better than zero
Better than
screening.
no screening.
So
Absolutely.
whatever you could get your hands on, use it.
Thank you. I was quite interested in the microwave ablation technique that you presented for the liver mets and so on. Which other center in the region may be indulging in that kind of technique?
Ablation therapy is available in Jamaica and in Trinidad and Tobago. I'm not aware of it being available in any other English-speaking Caribbean country.
I think it's important because I know of cases where what we call the non-traditional or traditional medical interventions, you know, our herbalists and so on, tend to offer hypothermia. And some people may confuse that with ablation therapy. Can you speak to the presence of alternative medicine and its effect in cancer patients in Trinidad?
Yeah. I think when we treat patients, we have to treat them holistically. That means that we also need to take into account their beliefs, because what happens up here will affect the way that they respond to different types of treatments. And therefore, when I encounter patients who need medical treatment, I don't hesitate to tell them, if you have something that you want to try that's not proven, by all means try it. But it doesn't have to be either or. We can do them simultaneously. And that is how I encourage patients to approach non-traditional or alternative medical care. Again, all of these treatments that we've talked about are tried, tested, and proven. There is a wealth of data available to as testament to their to their effectiveness. But these alternative therapies, really, you may hear ad hoc stories, but they're not tested, they're not proven. But I don't stop my patients from doing them because we need to treat them holistically.
Yes.
There is, however, Owen, we have published data to show that when patients who have cancer come in, one of the we even gave it a name. We gave it the name the substitution theory, and it's basically what we're saying is that Caribbean patients like to substitute medical care with obia and these non-traditional types of medication. And we've shown it quite clearly that when these patients come in and they've tried that before, they always come in at a more advanced stage. They always come in with tumors that are less responsive to treatment simply because they've wasted time and waited too long. Substitution theory. But there's a significant difference in their outcomes compared to people who seek appropriate care early.
Absolutely. I mean, apart from the majority of our patients presenting in later stages because of the absence of screening, early diagnosis, and so on, you know, we also have the fact that there's a cultural hindrance to seeking healthcare in our region. I suppose in the more developed countries, that may be less so. More healthcare facilities, government-sponsored healthcare treatment, and in Trinidad, especially Barbados, government-supported public health, free of charge to patients. In the rest of the region, most healthcare is privately run or out of pocket. So, you know, I think there needs to be, as I indicated earlier on, especially general knowledge of the work, the expertise that are available in the region, like yours, for, you know, maybe referral centers for specialized interventions where it can be done on local levels, but also a whole of society approach, as you've alluded to as well. that all of us, NGOs, laypersons, doctors, all the fraternities and societies to come together to help our population do better, because we can do better. And sometimes we can do better than the first world countries, as you have pointed out in your presentation. Do you have any final words for us, Professor Kowich?
I just, again, I'm very happy for this type of forum, because this is something that we need to publicize. The simple fact that we need to educate ourselves and empower ourselves to do better. And now I think the audience has a plan. They have a template they can follow. They know what they need to do in terms of prevention and early detection. So again, I'm grateful to Dr. Gabriel and to the entire forum. Thank you very much.
Thank you so much for blessing us with your presence. We have been honored to have you on. I hope we can reach out to you in the future for more presentations if you're not averse to it. It's certainly been a learning session for all of us. And there are many more questions on the platform, as you can see. But I don't think we have the time to. We are way past our estimated programming. But as we have seen tonight, I'd like to thank both Dr. Rohan Deshawn of Milton Cato Memorial Hospital in St. Vincent and Professor Shamil Kowich of the UWI St. Augustine campus for their excellent presentations. Very well put together, impactful, very clear guidelines as to the questions of prostate cancer and colon cancer, and the expertise that are available to deal with them in our region, and the need for screening, early diagnosis, and health-seeking behavior by our cancer patients, and especially all our communities to come together to make our world a better place. Thank you all for coming this evening and being here with us, participating in this very nourishing discussion for men, but for women too, and for families and our communities. Thank you all for being here, and we hope that you will join us again in the next live session of the Caribbean Cancer Portal. We hope to have you, and we'd love to have your feedback on the portal as you have been sent the links towards our cancer portal. Thank you so much to Dr. Lyndon Telesford and the hardworking team at St. John's University in Grenada for putting this together and helping us present this wonderful evening of men's health and men and cancer. Thank you all, and have a wonderful evening, everyone.